Hello and welcome back to The Halfway Point. Today we're going to talk about ways to generate more income as well as ways to review our spending within our practices. I'm pleased again to be joined by Tracy Dell, who's one of the directors and founders of Locum Practice Manager. Hey Tracy.
Hi Ben, and nice to meet everybody.
And this talk it's not about cutting corners, but it's more about being sharper, more strategic, and making sure no opportunity is being missed and money lost in practices. So when we're talking about income in NHS Primary Care right now, it can feel quite tight. From what you're seeing, is it generally getting harder to generate income, or is there still opportunities practices are not fully using?
I think we've got to just maybe think a bit differently. There's the standard, isn't there? Are you signing up to all the enhanced services? Are you maximising your target? Are you being target driven, and are you kind of going for those targets? And most of us are doing really well with QOF now, so it's become a lot harder. And I think we had that lovely luxury period of COVID where we had a lot of money flowing into the practice, blooming hard work, but we did generate masses of income for the practice. And we're starting to, if we're comparing ourselves to that era, yes, we are losing a lot of money. I think it's much harder to drive efficiencies, probably easier to drive some more income, but never say never. There's always other opportunities out there, and I think we can just think a bit differently, and we'll hopefully talk about that with you now.
So when you're going into a practice, what's the first thing you look at financially? Is it kind of the income streams, expenditure, or something else? What do you see?
I think the biggest area of expenditure in practice has got to be our staffing, hasn't it? It's kind of, I think it ranges from, kind of 50 to 65% of our NHS income is spent on staffing. It's the most valuable resource, but it's also the most expensive resource. So I think workforce has got to be an area of focus. And usually we're already in there working to create a happier workforce anyway, or to kind of review roles and responsibilities. So staffing's definitely a big area, and the workforce. But I also think about some of the smaller things and the very simple things, because it can range massively. And I'm all about marginal gains, Ben, to be honest. We make thousands and thousands of pounds, but if we make lots of hundreds of pound savings multiple times, it just all adds up.
It looks like, the income generation might be becoming more limited, core funding is stretched, but I think there are still some opportunities. So kind of as a first example, medical students and trainees, there is work involved in managing them, but they do generate income and they also add the workforce capacity. How have you come across, and how have you found like the medical students and trainees over the years?
I think it's different for me now, not just being in one practice and being in different practices, because it's opened my eyes to the fact that there's a wide difference between the different types of students that you have, and this is kind of medical students and also the nursing students as well have really opened my eyes. And I think having the variety, I don't think it's about relying on the students that the partners want in the practice and they want to support. I think we've got to push them a little bit. And so if you can get the students that, generate a little bit more income, it might be a little bit more work. But as you said, if you're helping to sort of drive your access targets up, and you're giving patients opportunity of choice of clinician as well, I think there's also lots of different things we can think about, but don't rule anything out. Tap into that unmet, kind of resource with your nurse leaders as well, practitioner leaders. And I think also, I know we're all kind of quite cautious now, I think, aren't we, about physician associates, but let's start thinking about these new roles that are coming. We're all completely on board now with advanced clinical practitioners. That's becoming a really valuable resource now in practice. So the only way we can make it work is by bringing them in and kind of investing in that time to get them going. But don't just look at the people coming. Do some figures, do some costings. See which type of students take less time but earn more money. And it's okay to do that. We are a business as well. We're allowed to kind of look at the figures and say, oh, actually, we're going to go for a different year of student rather than, the one particular type of year student, because we actually feel the benefit more in this practice, and it'd be different everywhere. Different in each practice.
Yeah, I think that's a good point as well, around looking at it from the financial point of view, as well as all the other benefits. You don't want to make a loss on it.
No.
And I think as well, just kind of expanding that. So I'm talking about the clinical roles, but apprenticeships for the non-clinical roles. There might be the opportunity there that you're creating a practice manager of tomorrow from the ground up, from a reception or a managerial apprenticeship scheme. So there's great resources kind of across the country in them. Have you had experience? Have you seen the apprenticeships from the non-clinical side evolve?
Yeah, absolutely. I think my favourite role has got to be the GPA, the general practice assistant role. That's one of my favourites because it crosses both areas, doesn't it? Clinical and non-clinical. And again, there's grants and there's funding available. So grab that opportunity, if that comes along. I think the role can then be directed in whatever way you want. We're very familiar with this now that they've come through the primary care network as an R's role, haven't we? But I remember introducing a GPA in practice more 9-10 years ago, and we had a very promising receptionist who wanted to take bloods, and I was like, do you want to do some other things as well? Not just bloods. Don't just think about phlebotomy. We can maybe widen your horizons a little bit. And I think there's lots and lots of benefits to bringing in apprentices. And let's not just think about young apprentices as well. There's mature apprentices out there. So
fair point, yeah.
Wide range of different ages, different backgrounds of people coming into practice. And again, it's we always pay our apprentices fairly. There's the recommended amount to pay the apprentice.
The national minimum apprentice wage
for an apprentice. We've always taken a little bit of a step back from that and said, well, actually, we can do the national minimum wage for everybody, regardless of how old they are. So that was always one benefit of doing the right thing because you can. And I think you can maximise that. If you're already instilling value in that individual as an apprentice, they're going to see that as a good place to want to be working in as well. So they'll see further ahead than their apprenticeship sort of period of time. But yeah, I think the most obvious one is now about growing our own. It's much easier to grow a manager from within than it is to bring someone in from outside. That said, there's benefits in both, isn't there? Bringing somebody in from a different environment. I'm a fan of managers coming in from retail, for example, because they've got those extra skills that we don't have in primary care. So I think, again, it's about knowing what's right for you, but definitely the apprenticeship programme has a lot of opportunity and you get a lot of support from the organisations that run them as well. So you invest in the training time, you invest in that supervision and managerial support and coordination of their role, but they will then have that extra support from their external apprenticeship organisation, and we can work hand in hand with them to where they need to be.
Just thinking about if practices are looking at where to start with these, I guess the registrar students would be the deanery, or if another practice that's got students in, you go to them. And I suppose in the same way with the apprenticeships, and through governmental schemes.
Absolutely. And think about, the levies have changed. I know that there's been alterations.
True,
but it's still a viable solution, regardless of that. But I think we're really responsive to each other, aren't we, as practice managers? We trust each other. And if you've had an organisation that you've worked to support that, or another practice have tried, the different types of medical students and found that, that they've had a tougher time with a certain type of student. It's great to hear that firsthand, isn't it? So you can probably of a little bit of pain from actually doing it in the first place. So talk to each other, but there's definitely help out there. Your LMCs will support you as well, I think, with things like that. So I think just reach out to anybody. And I think we're doing things better as a PCN now, aren't we? We're learning a lot from each other. Now that we've been forced together as groups of practices working to deliver the enhanced service contract for the PCN, I think there's a lot of positive spin-off from that, working more at scale in a sort of settled environment that we feel comfortable with. I think we're starting to feel more comfy out with our PCN peers.
I think that's great. And then so another way I've found, it takes effort, but it can be a good steady income once it's establishes kind of research work. So how hard do you think it is to become a research practice, and is it worth the long-term investment? How do you feel about it?
Totally agree, Ben. It's definitely about the long term. I mean, you've got to start small and build and aim big. And I think at first, some of the smaller projects that you take on, I think, again, it's about using the right people in the practice. And when we've done this in practices where we've started on the research journey, if you like, there's also lots of grants that have been offered regionally as well with this to get you going. If you want, I think recently with a practice, we were given a £1,500 grant to express an interest in becoming a research practice, taking some steps and sharing some information about what would work for us and what we'd like to get involved in. And then, of course, that's your baby steps to get going. I think you do have to start with the smaller ones, but a lot of the work that's involved is mainly admin. A lot of it can be dealt with by your clinical administrators and your admin team. And there's management input, obviously, but your nurses, your nursing team, so not just
Mm.
nurses, but your nurse associates, your practitioners, your GPAs, your healthcare assistants can get involved in things as well. So I think it's about getting comfortable with the idea of being a research practice initially and doing some of the smaller schemes, building up to the larger ones as a practice, but again, doing them at scale across the PCN. There may be a leading practice in your PCN that wants to kind of take the lead on the research and coordinate things for you. Doing things at scale is probably going to bring you a bigger reward, I think, financially.
I think from my own experience, I think this is one, well, sort of need this for all of this, but I think this is a big one where you need a partner or director clinical input to be on board from the beginning, because there's a lot of responsibility as well with the research and the screening of the patients and stuff like that, and it's a lot to take on just as the one person in the practice. So it sort of becomes another team almost, just as much as like the reception or your workflow. And yeah, I say it's a long-term game, but it can be rewarding once you're established and you've got that infrastructure in place. And that kind of leads into the third area that I was thinking about, was around pilot schemes, because some of the stuff we've done in the past of research is, you might end up with the equipment at the end of it as part of the research project. Same with the pilot. So, have you had kind of success with working with ICBs or NHS England kind of enrolling stuff out across the country? How's that gone
Yeah, I think the first thing I volunteered for, and people that are as old as me will probably remember the old Choose and Book, or Booze and Schmuck as they used to call it. The Choose and Book scheme that's now the NHS referrals.
Yeah.
We were the ones that were like, yeah, we'll pilot that. And we started by email at first. And then obviously we went on to the portal option. And we're now obviously way more advanced years down the line with the NHS referral system and everything, and being on the app and all of that. I think I've always been one for jumping up and saying, let's give that a go. Because I think what you can do as a practice is you can then benefit. I remember we rolled out a scheme, an IT scheme, and we got like an extra 6 scanners. And now in some practices,
wow.
I go in and it's like 1 scanner per X number of thousand a patient.
Yeah.
And you're like, but we need one at every workstation in admin. We can't just manage them without buying them. So, the scanners at the time, I remember the scanners at the time were like £200-300, the ones we were using. So I think you're right. I think it's about not necessarily getting paid for being a pilot at something, but you can be the one that, gets the benefit of kind of the flexibility whilst it's still in its evolving stage and it's not set in stone. And I think digitising medical records has always been on my bid list. I've bid so many times to digitise patient records. So if any pilots come up anywhere near a practice where I'm in and a digitising option, I'm straight in there. But
there.
So yeah, get bidding. And I think the main thing for me is be bid ready. Already have a wish list.
Yeah.
Have a wish list. It might be really extravagant and it might be unrealistic, but have a wish list of things, certainly around premises, all your estate stuff. Think about what you really need in your practice and be bid ready. So almost have your kind of core areas of, what the aims of the practice are, what your strengths are in the practice, what your patient population is and how best you can serve that population, and be sort of bid ready. And obviously you can't have everything ready and just sign and send it off because you don't know what the criteria is going to be. But it's something that's happening a lot more recently. And, I've just bid for some extra funding in the West Yorkshire area for increased uptake of childhood IMS. Now, I know that's not rolled out across the country. I know that's specific to an area that's always had extreme difficulties, and it's been a challenging time, but we've been given some extra time for our admin team and our managers and our clinicians to have conversations with parents that we don't have time in the 10-minute routine consultation appointment. We can have a champion administrator now who will give the patients a call before their appointment. We can have the longer conversations around those patients that don't consent to the immunisations for the children, so we can explain the benefits, not just in a leaflet, not just in a letter, but a conversation with a clinician. And that's made a massive difference. Now, we've not made a fortune out of it in money, but we've been able to pay some additional time to our admin and our clinicians to get them to do some extra hours to raise our targets. And that's going to have a benefit on QOF, and it's going to have a benefit targets as well financially for achievement. We aimed for 10% increase in uptake. I think we're already there in the first 6 weeks of this pilot.
Wow.
Increasing that on that basis. So there's some really exciting ones out there, but you just need to be be aware of what's going on. And I think when we share things on forums, it's really helpful as well, isn't it?
Yeah.
You can say, ask your ICB about this. We're doing it in our area. Now, not everyone does the same thing, but if you know it's there, you can kind of know what things might interest you as a practice.
Yeah, there's a big thing that's like thinking about resources. For a long time, a lot of areas would cover drums on printers because it counted as resources. I know certainly in our area that's now changed, but it was something that a lot of practices weren't aware of because they looked at it as consumables. And so obviously, it's slightly too late for this example now, but don't ask, you don't know.
Exactly.
It's worth asking. And I think the other thing with a pilot, and that's a good example you shared, where you get it right, and then that creates a model that could be funded nationally, but even locally, if you're involved in the project, you can help shape it. So if you know it's going to be something that ends in a bit of work that you'll have to do, whether that's each year or just as a one-off, being involved in the conversation at the beginning, at least from a PM point of view, the return should be how do we say, reasonable, as opposed to some of the extravagant ones that we have here and then.
I mean, and aim big. That's the other thing. If you think that this is a project and you think, oh, actually, scale it up. I'm always really wary when there's no budget. And I kind of think, well, do you know what? What have I got to lose? If I aim for 20 hours extra nursing time and I only get 7, it's a win, So aim big when you're doing these projects, because often they don't really give an indication of, of what is available. They kind of just want you to put a reasonable request in. So the more resource you have, the more you can do, but you can scale it down, and it's much easier to scale it down than it is to scale it up.
Yeah, great point. Yeah. So talking about ways of getting more money in, but what about income missing income that you've already earned? So kind of how have you found it going into a practice and almost doing a financial health check? We talk about physical health checks, but a financial health check. What are things that practices can do to look back and review first, kind of on their list, to see if they've not been paid for something or have missed some income over the years?
Yeah, I think looking at trends and patterns is really good. And don't just wait for your annual accounts meeting. I'm quite looking forward to when accounts go quarterly, where we can start.
Yes.
When we're forced to do it, we'll do it. Obviously, nobody's going to volunteer, and I certainly am not going to volunteer to look at accounts every 3 months and have a meeting with the accountant every 3 months. But I'm kind of weirdly excited about that fact, because it's going to force me to start being a little bit more proactive. So I think I look at trends and patterns on a monthly basis. If you're the ones that are processing everything and it's one person, it's much easier. But now, of course, with our management teams being a little bit more fragmented, we may not do every element of the finance, so we won't actually notice as much of it going on, and we won't be as familiar. I think certainly LPM, when we do our kind of practice assessment and we do that scoping exercise with the practice, finance always comes up on our scoping document.
Yeah.
It's always the top of the list. And in some ways, I almost have a bit of a challenge, and I challenge myself, and we do as Locum Practice Manager members, is we challenge ourselves to actually make enough money so that we've actually paid for the extra resource that the practices have spent on getting us in. So it's almost like a nice challenge in a way, that if I can make some income alongside making some improvements to systems, processes, or whatever else, or just doing some temporary cover, it's actually quite a nice kind of a nice extra, if you like, an extra value that you bring in. But don't dismiss everything. You can find money everywhere, and you can see things that you've missed, but you've got to be looking, haven't you? You've got to be looking at it.
Yeah. So I think, making sure, especially if you're new to the practice, checking with the ICB, are you signed up to all the commission services? Your water rates, have they been claimed correctly over the years, or your CQC fees, all money that you've spent, you're entitled to it. It's your practice money. You've done the work, or you've paid for it.
Yeah.
And then obviously looking at kind of ways for where practices can generate money, like with the private work and stuff like that. How have you found introducing like card machines and stuff like that into the process?
One of my favourites, Ben, absolutely got to be one of my favourite quick wins of all time. I go into practices and I see that they've got kind of quite long-winded manual systems for private work. Now, private work's only an element of our income, obviously, but it's one that we can maximise. Fee lists haven't been updated for years. That will pay, if you update your fees slightly with inflation on an annual basis, that will pay for your card machine costs. the convenience factor, the safety factor, the financial governance alone, not
Yeah.
process, not having to handle as much cash. Very, very rare exceptions now. Most people will be able to use a card machine, whether they come in and do it or whether they do it over the phone. You've obviously just got to check your governance arrangements with your phone system. So you obviously stop recording when they're.
Yeah, in the card. Yeah.
So there's a lot of things to think about on the governance side, but most of the companies will give you guidance and give you direction on that anyway. I've found, and this is a fact, that most organisations in most practices that I've introduced card machines into has increased their private income. Now, I'm not sure whether that's because things have been going missing. I'm not trying to accuse anyone of taking anything, but it's amazing how, because it's more efficient, it's more of an attraction. Do you know what I mean?
Yeah.
It kind of makes life easier for the patient, but it makes life easier for us as staff and as managers to process that fund. You can get your systems to automatically kind of reconcile it as well, if you've put enough information in there.
True.
So great opportunity to review your fees, great opportunity to have a nosy around on other people's websites, because I know we're not allowed to share and have a monopoly on how much we charge across practice. That's deemed as inappropriate. But there's nothing to stop you clicking on a few websites and having a look, because most of us put our private fees on the website.
Yes, in the public domain.
And make sure that you're competitive as well.
Yeah.
And make sure that you're doing that efficiently within the practice, and you're processing things. Just saving time. Again, I keep going back to time, don't questions, but shaving a few minutes off different processes,
It adds up.
It all adds up.
Yeah.
So absolutely a fan of card machines. I don't have any specific one in particular. Some do them through the bank. Some use the little sum up machines or the terminals that they just buy online. I just think make it as convenient as possible.
Yeah. And looking at similar services that, are you finding going into practices that they might have either outdated services or they're paying two different companies or providers to do the same thing? Yeah, I can see you nodding. Yeah.
Honestly, I don't think we'd want to admit this, but it does happen. And I've missed it myself in my own practice. I'll be the first to hold my hand up and say, we're not perfect. We make mistakes. Luckily, I've managed to claw it back because we've overpaid on the contracts, and we had this huge credit mounting up, and they don't think to tell you. They're not going to get in touch with you and say, oh, by the way, Tracy, you seem to be accruing a bit of credit on this account. It's like you're still paying an old bill, Always worth checking, because sometimes when we get new telephone systems and other things, we forget about these little maintenance contracts that are lying there. I think my kind of biggest bugbear in the locum land is finding, people signed up to anything more than 3 years. I do not sign up to a contract. I try to get it to a year, 2 years if it's utilities, or 3 years maybe for a better deal. But things like print solutions, bane of my life, franking machines, unless we're huge, big organisations, franking machines are not really cost effective. But then we think, well, hang on, I'm in a contract for 5 years. As a locum, I go in and say, oh, I noticed the practice have signed up for 5 years. And I think at first I used to feel a bit defeated. There's nothing I can do about it. I've started working it against them now. So I'll ask for a buyout fee. How much to buy out of this contract? We're not using it anymore. Obviously, they'll come in with something ridiculous, like they always do for print solution machines. And then I'll say to them, all right, fair enough. Well, we're probably not going to bother using it anymore. I'll unplug it, stick it in a cupboard. We'll have to pay the lease on it, obviously, but we're not usage costs. We're being much more effective with our print solutions. If there's a printer in every room, you're encouraging people to hit the print button, aren't you? You're making it convenient for them to print. I'm like the print police in our practice. Everything's defaulted to black and white. Everything's defaulted to double-sided.
Two-side, yeah.
We're not print single-sided in our practices. And I always do the think print. Do I need to print it? Can it be sent as a text? Can I copy and paste it and send it as a message? Do I really need to print this out? Nurses generally don't need printers in the room unless they're prescribers. I think it's really, everything's electronic now. You can send things to front desk for printing if it's patient leaflets. They've usually got a label printer, or they've usually got a zebra printer for the cytology. So I think be a bit brutal, trim it down a little bit, go a little bit into that territory where you're sort of saying, do I really need this? And make it a bit harder a bit less convenient, if you know what I mean.
Yeah, absolutely. And kind of, what about bulk buying, or even kind of looking into your consumables pricing and comparing that? How do you feel around looking at some kind of external companies, or even just bulk buying? So rather than doing the shop for the month, doing it for 3 months, or even longer.
Yeah, I mean, if you've got the space, it's great. I mean,
Yes.
the biggest hurdle is space. I mean, couch rolls just take up so much room, don't they? It's like, these huge big boxes that come in and stuff. So if you've got space in your practice, I think it's a good idea. And if not, I think you just need good stock control, good minimum stock order levels as well for your things. If you make it easier for people to see what they need when you're doing that stock check and you've got your minimum stock order levels, we do it with drugs, don't we? We're really good with our medical supplies. And yeah, we can do that on the clinical systems now as well, can't we? So let's get doing that with our sort of janitorial and our stationery items as well, our kind of non-clinical consumables. And again, I think things like high capacity print toner cartridges, much more convenient and much more money saving in the long term. Might be a bit of a layout initially.
Yeah.
The high volume consumables, but in the long run, we'll save money. If you adopt the same principles as you do at home in your own sort of, being economical, treat it as your money in the practice.
Yeah.
You can't go far wrong, can you, with that? But yeah, difficulties if you've not got places to store things. But buying groups, again, you've just got to make sure that you bargain with your suppliers. If they're going to put prices up, kind of challenge them on it. Don't just lie down and accept it. Say, we might need to look elsewhere. We do it with our insurance renewals and things like that, don't we? And
yeah,
that gives us an opportunity. So not just the expensive, suppliers. You can do this with others as well. And yeah, I think you've just got to think the same way as we do at home. We're having to, the cost of living crisis.
Yeah, absolutely.
At home. I think about this with energy all the time. Would you make sure the tap's turned off properly at home? Yes, you would, because you wouldn't.
Yes, you would. Yes.
Yeah, Would you leave lights on all over the place? No, you wouldn't. If you're paying the bills, you don't want to do that. So I think, not just thinking about it for cost savings, but obviously for our, a greener practice as well.
And I think it's stuff like, if you're doing a stationery order and you need another couple of quid for that free postage, you're going to buy the paper anyway, or you're going to buy whatever it is anyway. Just buy it earlier, and then save yourself on that postage cost. It's easy sometimes just to click it, and then like you said, the postage gets added on and you just pay the invoice. So I think, so kind of wrapping up then, I think it's it's clear income might be getting tighter, but there is still room, I think, for smart leadership. And I think the takeaway for me is, the small changes add up, as you've said. That minute here or that pound there can add up really quickly. But I think also it's, the manager doesn't need to have to solve it alone. LPM are there, other companies are there. Do reach out, don't struggle. So thank you, Tracy, for being with us today and sharing such valuable insight. If you found the episode helpful, make sure you follow or subscribe so you do not miss next Wednesday's release. If this episode helps you, please let us know in the comments. And if you think this episode would help a colleague, please also share it with them. You can connect with us at LPM on LinkedIn and Facebook by searching for Locum Practice Manager. Otherwise, hope you have a good week, and we'll see you next week at the halfway point. Thank you very much.
Thanks, Ben. Bye, everyone.
Following the success of LPM's very first New to Practice Manager conference, we are bringing them back with dates right across the country. This year, we're heading to Hull, Salisbury, Newcastle and Preston. And the best part, it is completely free to attend. If you're new to the practice manager role and feeling like everyone else has the manual except you are not alone. These conferences are relaxed, practical and honest. Real conversations, useful learning and tools you can take straight back to your practice. You'll also meet trusted industry partners, leaders in their own field who are there to support you and help you grow with confidence. You will leave clearer, better connected and ready to lead. Head to locumpm.co.uk to book your free place and follow us on LinkedIn and Facebook to stay up to date. We would love to see you there.